let people jump in, and then we'll start off with our speakers. So first and foremost, thank you so much, everybody, for coming. I know it's a weekend and everyone's time is very precious. So good morning, good afternoon, good evening to everyone, wherever you're joining from us today. My name's Adel. I'm a neurosurgery resident at Duke in North Carolina in the United States, hoping to subspecialize in skull-based neurosurgery. And it's a real pleasure today to be joined by two amazing co-hosts, Dr. Muhammad Abdel Bar, who's a professor at Duke and an expert in minimally invasive spine surgery. And he's also the co-chair of the WFNS Innovation and Technology Committee. And of course, renowned skull-based expert Dr. Daniel Prevedello of Ohio State University, and also co-chair of the WFNS Skull-Based Surgery Committee. So just as a brief background, as you all know, over recent years, global neurosurgery research has seen a huge explosion. And fortunately, with that has also come some neurosurgery capacity. Especially in the background of that landmark 2015 study from The Lancet, which showed that in low and middle income countries, we need 143 million more surgeries every year, with neurosurgery comprising a major need. So rightfully, much of the initial work has been devoted to building out the trauma care in neurosurgical sense. And as that has continued to develop, it's, I think, incumbent upon us to grow other areas of neurosurgery as well. And tumor surgery, especially skull-based surgery, is another critical unmet need. Traditionally, it's a more resource and training intensive subspecialty within neurosurgery, which may lead to it being a bit slower to develop. And even with less resources, physicians and LMICs are asked to do even more, for example, with tumors presenting larger and later in the clinical course. So in those settings, how do you weigh the trade-offs between the extent of resection and possible complication avoidance in a context where redo surgeries really strain the patient and medical systems? So there have fortunately been a few recent papers highlighting the experience in some countries regarding skull-based surgery, but really we don't have a good sense from a global perspective where we're at. So today I hope that we can hear the stories of the growth of some skull-based programs, including challenges and successes in 3 different countries. And we hope that hearing these stories will shed some light on what is possible even when resources are more limited, and then start a conversation about how to continue expanding our ability to care for these patients who need our neurosurgical expertise. So before I introduce our first speaker, I'll hand it off to Dr. Abdelbar to see if he has any other introductory comments, and then Dr. Prevedello as well.
Great. Thank you so much, Adel. And first of all, I'd like to thank Adel for his really humongous effort. He came to me with an idea and he, basically took over. And this is so great to see this culmination of his effort. I think it's great for us to really see, what, as he said, the unmet needs, and also to see how other countries that may not have as much resources have dealt with these issues. And as the chair of the innovation technology, it's been really my goal to show that this transfer of technology should not be unidirectional, it should be that really bidirectional. And there are a lot of lessons that we can learn from other places of how to actually treat these tumors and so on. So I'm really looking forward to this webinar, and thank you all to all the speakers for giving us their valuable time on the weekend. And thank you all to all the people that are listening.
Thank you, Said. I just would like to say a couple words and congratulate you for these amazing initiative. I think this type of initiative is what we need more, not just talks about diseases and things like that we got a little tired doing COVID and all those webinars. I think this is very important to help the world to develop and to overcome all the difficulties that we see, particularly in countries that are still developing. So I think this is it's a great initiative. Hopefully this will be recorded so many more people can watch it later on, and appreciate it.
Perfect. Well, again, thanks to everybody. So now to what you actually came to listen to, our first speaker, Dr. Clara Karakezi. So she has an amazing story that I've just had the pleasure of reading about, and it's great to meet her for the first time today. But she's a senior consultant neurosurgeon at the Rwanda Military Hospital and a senior lecturer of surgery at the University of Rwanda. She got her MD from the University of Rwanda and then completed her neurosurgery residency in Morocco in 2016, before then doing fellowships with a special interest in neuro-oncology and skull-based surgery, first at the Brigham and Women's Hospital in Boston in the United States, and then at the University of Toronto in Canada. She then returned to Rwanda in 2018 as the first woman neurosurgeon in the country and has won numerous awards for her leadership. So today we're really excited to learn from her regarding building skull-based surgery practice and training in sub-Saharan Africa. Dr. Karakezi, take it away.
Thank you so much. It's a pleasure being here. Pleasure sharing my experience, my practice, and how we're building skull-based surgery in Africa in general, and especially in Rwanda. So without further ado, I'm going to share my screen. You just let me know if you're able to see it.
Yes, looks perfect.
Okay. Okay, great. So I didn't choose to talk about skull-based building in my own country, but I thought it would be much more broad, talking about sub-Saharan Africa in general. I have no particular disclosures except that I'm a coast co-director and in the 360 degree skull-based course that we just initiated at the IRCAD Africa in Kigali, Rwanda. And we just had our first course that I will be talking about. So we know that neurosurgery comes as one of the youngest surgical discipline, and it had many years of ineffective neurosurgery with several complications until Kashi, when he came and he was able to do some surgeries with acceptable postoperative results. And then over the last years, we've seen neurosurgery evolving. So I think we had an era of improving between 90 and 2000, where we saw an incredible increase of neurosurgical techniques, treatment, new areas in the fields. And then, as you just said, in 2015, with the Lancet publication on global surgery, surgery became a concern in general. And then I think it was around 2017 that people really started talking about neurosurgery in LMICs and other developing countries, because not much was known. And global neurosurgery came as the clinical and public health practice of neurosurgery with the primary purpose of ensuring timely, safe, affordable of neurosurgical care to everyone. And then I think over that decade, around 2000, 2020, has been a lot of development in neurosurgery, especially in most LMICs countries. We saw an increase of training programs, an increase of neurosurgical workforce. And then 2019, I think, was an era of diversity. 2020 became an era of decolonizing global health, because even if those help were coming, they were coming in an adequate way. And then I think in 2022, 2023, we're talking about era of decolonizing global neurosurgery. So what about those programs that came to help? Were they sustainable? Did they really help the neurosurgeons that they came to help? That was really the real purpose. And African neurosurgery, without surprise, was almost left behind. Many causes were there, lack of financial resources, paucity of neurosurgeons, inadequate healthcare plannings, inadequate political, economic, and social environment, political instabilities and wars in most countries. And really, not a lot was known until this master paper that came in 1998 from Absalam El Kamishi from Morocco. So you can see that of the 565 counted neurosurgeons in Africa, that was 1998, only 79, which made like 14%, were practicing in sub-Saharan Africa, which was a rate of almost 1 neurosurgeon per 7 million. So this limitation of workforce was one of the major barriers to neurosurgical care in sub-Saharan Africa. And in most countries, neurosurgery was not regarded as a priority. It was considered as a luxury care. Most people thought it was expensive, individually focused. And what was priority at that time was primary health care, malaria, maternal death, in those countries well developed. This the master paper that I was talking about. you can see that, with 5 billion people lacking surgery, and global neurosurgery paper showing that most sub-Saharan Africa really lacked neurosurgeons, and it was about to do something. So papers kept coming, talking about education, state of neurosurgery in Africa. Lastly, I think it was 2020, we're counting around 1,500, but you can again see that even if we came in sub-Saharan Africa, we came from 79 to 512 that time, we're still lagging behind. And then I think of the latest numbers, maybe Africa is counting more than 2,000 neurosurgeons. And this is a very recent paper published in 2024, showing that still of the 7,967 worldwide neurosurgeons, Africa was having the lowest density again, and most infrastructures were not still well developed. So Rwanda is any sub-Saharan Africa country. Not much was known since 2007. 2007, the country had a CT scan, one CT scan, and I was a medical student, you can imagine. And 2007, we had one first neurosurgeon who trained in China. Our first MRI in 2010. By 2011, we had only 2 neurosurgeons, no local training program. And in 2011, I had no other choice except finding a training abroad. So I left for training, and my colleagues started a training with 3 trainees in 2012. And I came back, as you said, in 2018. And so far, we're counting a neurosurgeon for 14 million people, still far, but we made some progress. We count 15 residents. We have 2 programs, the University of Rwanda and the COSEXA, which is a regional program. And we count more than 10 CT scanners. Rwanda is a pretty small country, so it's possible to have a CAT scan in a short time. And we have about 6 MRIs. So what about neurosurgical education? So neurosurgical education, this is one of the papers I think we wrote in 2021 with other young African neurosurgeons. We found that there were about 76 training programs, and top programs, again, were still located in Northern Africa. And there was no standardized training. Most of the training were about 5 years in medium, but going from 4 to 7 years. We again looked at the curriculum. We found that there was no standardized curriculum. Again, programs going from 4 years to 8 years. And in Rwanda, we made similar progress, increasing trainees and producing more neurosurgeons. So this is how any neurosurgeon in sub-Saharan Africa, I think this is not me, just me, but most of us started like this. You go back, they give you a job, and when you start, you have something like this. You have just one set. If you're lucky, you have I was like, I figured out that they have a Mayfield. They didn't know how to use it. So I just got it, and I was able to start my practice. So when you start your practice as a young neurosurgeon, you can imagine the practice doesn't come easy. It comes with more challenges, and you're asking yourself, should I do less? Should I maybe prioritize trauma, as you're saying, but how about like those, complex spine cases, complex vascular cases, complex tumors? Who is going to do that? How to build those competent neurosurgeons able to tackle those challenges, and how to keep growing, and how to keep making African neurosurgeons growing. So, some of my first cases, I was just doing everything with very minimal resources. You can see that I started operating. I will show a couple of cases I started doing, including my first skull-based cases, with just a headlight, my loops, and Hudson brace, and a couple of jiggery saws. Tumors, come very small. And I was relying on donations in the beginning, and I was still pushing the administration to invest in neurosurgery and in the equipment. So you can see that I got some donations, but again, some of the first cases did not come very easy. Everything came huge, as you say. Each tumor was huge. Each trauma was crazy. And, it's not just like what you just learn in school. You have to tackle all these challenges. So these are some of my first skull-based cases. I think this was a 60-year-old female who came in with this big sphenoid wing meningioma. I think it was more medial, but pushing the MCN carotid on the side. So you have to plan, because I had very limited resources, but I had to help her. This is a tumor pretty much removed easily. Was surprised, and patient did well. Some of the next case, this case was a sphenoorbital meningioma with this destroyed orbital and temporal bone that are removed and did the reconstruction. Small lateral sphenoid wing meningioma again, done beautifully. And then I started seeing those OGMs. I would say this is very small compared to what we see generally. Great removal, patient did well. This was a tuberculum cell meningioma, and this was more of an OGM or frontal meningioma removed. This was an NF2 case that was complicated because this patient presented with a huge meningioma, bilateral vestibular schwannomas, and you can see a C4, C3, I think, schwannoma that I first removed the meningioma, and then the schwannoma in the cervical spine, and I was still planning to remove the vestibular schwannomas. So our modern neurosurgery equipment, you can see they remain very high and very expensive in LMSs. If you look at everything you need in the theater, everything maybe altogether will cost more than $1 million US. And in most countries, this is just too much, and it's very hard to convince the administration to invest it. But you have to keep pushing. This is us last year, so we kept pushing. It took about 4 years, but we finally got our first microscope, and we got a tower. We got all the set, Cababianca set, and ATV set. Just because I would sit on the table and I would tell them, these patients are there and they need to be done, and you have to invest. And we're still building, I think, a low-cost navigation system with Alex Golby, who has been visiting more often. She has come to Rwanda 3 times now. So you can see that this allows you to tackle more bigger cases with more visibility. So you can see how OGMs come. So I don't even know if this is an OGM or tuberculum cell or what. It's a combination of everything. It comes from front, goes behind, and it's very hard to do this with just your eyes, and you need a very good visibility. So this is a patient that I did with a brand new microscope, and she did pretty well. So we were able to decompress her optic apparatus. So this was another complex patient who presented with this third ventricle tumor that was thought to be a craniopharyngioma, but I think the tumor was more of a optic pathway glioma, because it was more of a solid tumor. You can see the exposure, the visibility, pretty much good resection, but this patient had a DI, and he passed away from hyponatremia. So even if you do a good job, even postoperative periods can be challenging in our settings, because you have to take everyone with you. You need endocrinologists, you need everyone who understands, and you need a good follow-up of patients. So these are a few of my craniopharyngiomas. I just decided so they come also huge craniopharyngiomas. And I just, most of the patients are poor. They will not afford hormonal replacement. So why not doing less? So I'll put just a catheter, let the cyst come down, and most patients did very well. So this is another case. So when you look at the cases I receive every day when I do my clinics, so it's just every skull-based pathology that you can imagine, from pituitary adenoma, crazy. I think this was one of my latest case. It's tuberculum meningioma that goes down in the prepontine. I also had this foramen magnum meningioma. So every case is a bit challenging and requires a bit of training in skull-based surgery. So in 2021, again, we did a survey. We surveyed about 112 young residents and young neurosurgeons from 20 countries in sub-Saharan Africa. And we asked them, what do you need? What do you think should be done to help you growing? Because we have now so many programs, and everyone is able to do trauma and the basic neurosurgeries. But most of them, what they responded, they said they needed subspecialty training. They needed to train in those complex cases, either skull-based, spine cases, and they said that they needed cadaveric causes. And when you look at cadaveric causes, very scarce on the continent. And I think even in developing countries, in HICs, these causes are maybe started not long ago. But this remain maybe the most adequate simulation you can have before tackling a very complex case. So in most LMICs, including Africa, those causes are almost non-existent. And you can see that most skull-based surgeons, even if they will call them skull-based surgeons, they will still tackle all cases via conventional pterional, suboccipital retrosigmoid, subtemporal approaches. But all those other crazy approaches, not really very mastered or really very known, because you need to be in a skull-based laboratory. You need to practice. You need to demystify those approaches so you can be able to do them. So when you go in the skull-based laboratory anatomy, you learn the bone structures, major arteries, venous structures, perforators, cranial nerve relationship, and you learn how to handle the drills, the bars, and everything, all those small details, but very important details in skull-based surgery. So unfortunately, those courses need investment from government, from health ministries, and from partners, because most of the equipment that are used in the courses are very expensive also. So I think you heard, I will talk about ICAD Africa, but this is an example. I think this is a skill laboratory that was set in West Africa by my friend Landry Conan. So they started with very few tables, but they're able to do courses every 3 months, and they do basic suture technique course, how to use a high-speed drill, for instance, skull-based. They did neuroanatomy and endoscopic approaches, and they did a couple of spine courses as well. So this is one of the great examples, and I think they are among the few people that have a skill lab dedicated to skull-based surgery. And we tried to do a similar course. I think that was 2021. So that time, ICAD infrastructure was not built. You can see this for Professor Fresh. So we were able to get 4 cadavers, and we had a few trainees. And our main sponsor was TOLS, so we did mainly endoscopic approaches, but we could not do, we're not prepared to do open approaches. But from there, we knew that the ICAD Africa was being built, and that eventually we can set an adequate skull-based course like in any other country. So I will talk about the ICAD Africa experience. You can, I think some of you know that ICAD started in Strasbourg, France, and started expanding in different countries. So The one institute that is in Africa is located in Kigali, Rwanda. So to build this institute, my government invested more than 20,000 US dollar just for the infrastructure. The infrastructure is magnificent, very nice infrastructure, nice auditorium and nice lab with 15 tables plus one master table. So with a capacity of training 30 trainees. So we started with different specialties, including ENT and neurosurgery, joining together to do the skull-based course. So in the beginning, of course, because the institute was launched last October, we could not be among the first one to conduct a course because you need a couple of things that I'm going to show you to be able to conduct a real skull-based course. But some of the discipline were running and they were using pigs as anatomic species, and they mostly do laparoscopy, so stalls was on board, and they did not need many equipment like neurosurgery. So when it comes to neurosurgery, we started advertising for the May course, I think last year. And even if we had a very well-equipped lab, so you can see that the towers and are already mounted. So we needed to bring all this stuff on board. So where to get microscopes, where to get head holders, where to get so to get the anatomical specimen. We already were in contact with our anatomy department at the University of Rwanda, and there is a law in Rwanda that allows to give non-claimed bodies for education. Otherwise, we will not be able to get the head specimen. But our anatomy department never injected a head. So they said we're going to fix the head, but we don't know how to do the injection because someone had to come and teach them how to do the injection. Anyways, so we had a couple of meetings since last year, strategizing, bringing everyone on board. So we could not get Integra. This is a very funny picture. I like to show it. I was in Italy for another skull-based course. So I asked them, where do you put the head? They told me, you just get a small basin like this. So I went in a supermarket and I saw these small basins, and I was asking this guy that works at the institute, can you put it on your head? Because I was at work, I could not go myself. If it fits your head, so then the head is going to fit. And so eventually the course was set. We had to bring in our partners and sponsors. These, I think, were equipment. This is just Sunday before the course starts on Monday, and everything had to be shipped in, customs and everything. So Sunday evening, finally we got everything from Medtronic, everything from Zeiss, and we're able to set our lab and to mount everything together. So these were our main sponsors. Source came in, Medtronic came in, this is our anatomy lab, Bissinger's Germany, company that manufactures some microsurgical instruments. And of course, Zeiss shipped in 11 small microscopes. Otherwise, we could not do the transcranial approaches. So we had a very good number of trainees that came from different countries. It was a risk because we weren't sure we're going to have all the equipment on time, but we took the risk. So we had everything on time. And this is us, the day of the course. You can see that the small basin, so it will move if you're drilling. So we had to find a way of fixing it. So this is one of the tech lab nurse. He was able to fix it on the table, and it was well fixed. So the course was very designed. Like I've attended the ICAD France several skull-based courses, and I would say that there was no real difference except not having Professor Prevedero, for instance, in Rwanda, because we weren't sure of the first course. So we only had Professor Flourish and one of his residents. but I invited a couple of colleagues from Senegal, Nigeria, Kenya, who came and gave some lectures. So mornings we did anatomical teaching and all the approaches they were going to do. So we decided we were going to have the exact same course as the one in France. So it was a complete 360-degree, and afternoon everyone enjoyed the lab. You can see we're so surprised. Though the specimen were not injected, the fixation was pretty great. So the skin was smooth, the anatomy layers were conserved, and we had a very successful course. These are some of the residents who were able to do many dissections, even as, you know, as course guiders, we were also, you know, improving and learning from each presenter. So this, my two residents, they were able to do an F2OZ, you can see, and I was very happy. And, you know, this is me and a colleague from Senegal. She does most endoscopic endonasal surgeries, and she was demonstrating the endonasal approach. So this was the panel of faculty from France, Nigeria, Rwanda, Senegal, and everyone came in, and all the trainees, and they were very satisfied. So, and these are some of the sponsors. I think these guys are from Medtronic, DICE, and our faculty members. I think from there, of course, you have to go several times, but each time you go, you become very familiar, and you feel more confident in doing adequately some of these approaches. And I will tell you that just after the course, I started seeing crazy stuff. Like this case, you know, when I was asking Professor Freud, she said, you need to do an F2OZ. I said, oh, can I really do an F2OZ on my own? I said, okay, let me tackle it. I just finished a course, and I was able to do a very nice F2OZ in this guy. I will pass, so you can see retrograde dissection of the temporalis muscle, exposure of the lateral rim of the orbit and zygoma, IOF identification, all the steps, just like I learned in the skull base. Otherwise, if I didn't go in the lab, I will not be able to do this. So McCarthy keyhole adequately, and you know, this nice piece F2OZ came in one piece. I had a little bit of orbital fat, sorry. I could not preserve the periorbita, and I was going down, taking down the lesser wing, and I think I completed with an anterior clinidectomy that you can see that I'm doing here. So when I opened, so the idea is to work in this corridor without having the bone obstructing you. You can see this was very nice meningioma. When I opened the corridor, the meningioma was just, you know, beautifully exposing itself. And I felt like, you know, I was in France doing, or in the US doing this complex skull base on my own, and doing a very nice approach. And at the end, I think you will see I expose the carotid, ACA, middle cerebral artery, and remove everything so beautifully, and patient did well. So this is the patient, nice cosmesis, doing well, and I was proud of myself. So I said, if I didn't go to the skilled lab, I would not be able to tackle such a case. Just after this guy, I get this, you know, foramen magnum meningioma. I said, oh, this one I'm going to kill her because I cannot, I can't. I said, okay, this woman, she's becoming quadriparetic. I need to do something. So I said, I'm going to do a far-lateral approach. So if I didn't go to the lab, I wasn't going to be able to do a far-lateral approach. So I did the far-lateral approach. I could not monitor any cranial nerve because I don't have any monitoring. I said, I'm going to use my anatomy. I'm going to check every fibers and make sure I don't take anything. Sorry, I'm about to finish. So, beautiful exposure. and the meningioma was just there, and I started bulking it. And this is, I think, at the end where you see the vertebral artery, V4 cavity, and everything well, nicely done. And she did very well. I was surprised she did well. I think I took a little branch of 11. She had a little bit of weakness in the left shoulder, but I'm happy I didn't kill her. Anyways, if I didn't go to the lab, I will certainly kill her. So this is what comes to you when you're in Africa. They will not come small. They come like this. So you have to be able to tackle them. This was a case I just did last week. It was going everywhere. Tuberculum, down, diaphragm, prepontine. And I did my best, but this patient is already blind. So, you know, a lot has been done. A lot has been done. We're still developing, but I think we can do better. We have the skills. We can have the skills. We can train our residents. We can train our young neurosurgeons, and they can become as efficient as any neurosurgeon anywhere. But we need to bring on table different partners. We need to bring on table government, health ministries, so they can invest in technology, because neurosurgery is a field that relies a lot on technology. So I cannot finish without thanking one of my great mentors, Prof. Gentili. When I was about to start my practice, he told me that he had, he was sure I was going to do just well. And he just had trust in me, and that helped me a lot. And of course, eternal mentor, Flourish, who has been behind all this skull-based development. And this is my beautiful country, and you can come anytime. Thank you so much.
Very good, Claire. I feel obligated to say the first words here because you mentioned me, and I just want to, in public, tell you that congratulations, first of all, beautiful work. And I just want to publicly state that I'll be happy to help you with the next course.
Absolutely.
Yeah, keep it. I wasn't aware of your course,
no, we didn't tell anyone because we weren't sure everything was going to come together.
But be happy to help in the next one. I guess we can communicate in parallel later, and then I'll be happy to help with whatever I can to establish a nice continuation of our great work.
Absolutely. Thank you so much. Sorry, I took so much time, but I felt like I had to tell all these stories behind.
Oh, that was beautiful, Dr. Caracas. I really appreciate the whirlwind tour of the entire sub-Saharan Africa experience, and especially the Rwandan experience. It is beautiful. So just being mindful of time, we can segue to our next speaker and then save some more questions towards the end, if that's okay. So I'll hand it back to Dr. Providello to introduce.
I would love to introduce Lucas Lima. Lucas Lima is, first of all, my friend. He spent several months. How long did you stay with us, Luke? 6 months doing research with us here in the Ohio State University. Lucas came with a lot of energy and eager to, expand the knowledge of skull-based surgery. Went back to Brazil. Now he does a great job in Minas Gerais, one of the states there. But more importantly, Lucas is worried about the development of countries that have more difficulties. So he performed an amazing study that he would explain to you all. And so it's our honor to have Lucas here to participate on this panel and give us his perspective on the development of skull-based surgery around the world, particularly Africa and in South America.
Mm-hmm. Thanks, Professor. It's an honor to be here with you. I'd like to thank Dr. Adil, Dr. Abdelbar, and it's a pleasure to be here with Claire. I admire her work, and to be here with Mikhail. Mikhail is my friend. We have projects together. I'm very happy to be here. So let's share my screen. Just a minute. Okay, can you see it? Okay.
Perfect.
I'm going to talk a little bit about the scenario and challenges of scope-based endoscopy in Latin America. So I want to show just a little bit about our experience, and then the most important would be to discuss the thoughts we have now, things, the projects we want to run, and we need help. So I hope you can suggest something and help us to have this done in the future. So I have no conflicts of interest to disclose. This is my city. I live in Belo Horizonte, in the state of Minas Gerais, Brazil. Belo Horizonte has the third largest metropolitan region in Brazil after São Paulo and Rio. So we treat about 6 million people here in Belo Horizonte. I made my training, my medical school here in Belo Horizonte, and then neurosurgical residence also here in the hospitals Felício Roxo and João 23, one public hospital and one private hospital. Then I went a period to the United States for observerships, and then I met Dr. Prevedelo. I spent there 6 months at the Ohio State University, where I had the opportunity to watch surgeries and work in the lab. In the middle of 2016, I was back in Belo Horizonte, and I started working in these hospitals. So here in Brazil, in general, we work in more than one hospital. We do not receive salaries, monthly salaries. I get paid by production. So most neurosurgeons work in more than one center. I work in 3 private hospitals where I have one reality, and in one public hospital, the reality is totally different, where I do not have resources for more complex cases. This is our experience. So I work here with neuro-oncology and scope-based surgery. I want the goal here would be to talk about endoscopic scope-based cases. This is half of my work here. And I would say that, so we work with gliomas, metastasis, meningiomas, the scope-based meningiomas, vestibular schwannomas. But for those cases, for microneurosurgery, there are more people working here. So I'm in a good center in Brazil with experienced people working with these cases, but this is my opinion. We still have a few people working, trained working with endoscopic skull base. So in endoscopic skull bases, this is our cases in the last 8 years. 390 cases, 2/3 of them are pituitary adenomas, and this will be my focus today, to talk about pituitary adenomas and how this can help in the meaning of global neurosurgery. I came from a service where the most experienced neurosurgeon performed more than 800 pituitary cases by microsurgery, transfenoidal microsurgery. And now we are in our learning curve with these 309 cases. And why to talk about pituitary adenomas? Everybody knows a little bit the Lancet Commission recommendations from 2015. Then we have this article from Dr. Dewan and colleagues. They estimate the demand of essential neurosurgical procedures per year, and it's about 13 million, almost 14 million procedures per year. And we have in first traumatic brain injuries, then stroke, epilepsy, hydrocephalus, and then brain tumors, about more than 700,000 cases per year. And when we see the demand of the cases that are not performed per year, it's almost half of those cases, more than 5 million cases per year. And what's the role of neurosurgery for brain tumors? We have a special interest in benign brain tumors. Why? Because for these cases, we just need surgery. So If we have a structure and if we have training for surgery, probably the patient will not need chemotherapy, radiotherapy, other expensive things. So when we talk about global neurosurgery, of course, we want to treat all the patients. All the patients are important. But when we are treating benign tumors, we can be more cost effective. We are returning with young people generally that can can make difference in the economic of that country. So when we talk about benign pituitary tumors, we have first meningiomas and then pituitary adenomas in frequency. And why we are going to talk about pituitary tumors? I told before, there are a lot of people working, and there are more neurosurgeons here working with meningiomas, with gliomas, and few people working with endoscopic scope-based surgery. So for me, the most common pathology I treat is pituitary tumors, and sometimes we receive friends from colleagues from other countries, other regions from Brazil, and we see that there are few people trained for these cases. Most of the time, there are people with structure, but they stop trying to perform the cases because of training. So the first challenge is to learn how to follow surgical principles for pituitary tumors. So when we have pituitary tumor, what we want to do? First, the reduction of mass effect. We need to preserve or restore the normal neurological functions, and we need to decompress the gland to improve or to maintain residual hormonal function. But also, I would put another thing we always try to do, that is total resection. So this paper from 2014 from group of from Cornell, they show that the quality of life of the patients is better when we achieve total removal. Of course, this is not always the case, but this is something we always try to do. I will put a few examples. I'm not going to talk about technical aspects of pituitary tumors, but just to understand what is our concern here. This is a normal pituitary tumor, a big pituitary tumor, 3 centimeters, normal case. So you can use different instruments. Here we are using a curette and a suction, and diaphragm goes down, and the tumor is soft. This is normal case. Most common cases are like this. And okay, if we have cases like this all the time, it would be easier to understand training. So this post-op. Another case, so there will be a few cases just to understand how we can improve our technique. This case, we are going to let's put more in front. We try to dissect the pituitary capsule, pseudocapsule. So this is something we always try to do for small tumors. When we have bigger tumors, we try to find the gland, and even we remove it in pieces. We try to get that plane between the gland and tumor, and do the extracapsular dissection, so to preserve the gland and have better outcomes. Sometimes we have cases like this. This is a fibrous adenoma. 7% of the cases are like this, and these are the cases where someone with less experience would leave a lot of tumor, and this is what we are trying to improve in our learning curve, and work extracapsular for cases like this. Let me pass a little bit. In a case like this, we can remove all the tumor. Patient is probably cured. from his disease. Gland is there. So pass. Are you hearing me? I'm trying to pass the video, but
Yeah, we can hear you, Lucas.
possible
We see
here.
the imaging with the four, with the MRI on the right side, and the video is going a little slow, but we can see it.
Okay, it's just running here. Okay. I have another two videos. I'm not sure if they're going to pass. So this is adenoma, GH adenoma with cavernous sinus invasion. So just to show for cases like this, we have to try to cure the patient and enter the cavernous sinus. The same thing we work here is carotid artery. We work extracapsular to try to remove all the tumor. I'll pass to the last case. So more complex cases. Here's a multilobulated adenoma with anterior extension to the third ventricle. And here we do a transplantal approach, like I learned from Dr. Prevedelo, and we start removing tumor in the second floor when the tumor is soft. I will skip the video and go to the post-op.
Yeah, we see like a
it's not working very well here.
We're not seeing the video itself, just random.
Okay. Okay, I'll try to skip it. It's loading. Sorry. Okay. Pre-op. Just a minute, not working. I'll stop sharing just for a minute. I'll put again. Okay. Okay. Now I see you. Just open again. I'll skip the videos.
Are you sharing now, Lucas?
No, not now. I'm opening again the keynote here.
The file.
Okay, so I put here. We are post-op of that case. And I'll stop. That was the last video. So yeah, I believe internet's not very good here. It stopped again. I'm not sharing, right?
Lucas, I think Rwanda's internet is better than Brazil's.
Yeah.
I think that has been clear in this session here.
I'll try. Just a minute.
I think I'm curious to see Mozambique's maybe better as well. Let's see. I'm curious.
Okay, Wi-Fi. Let me put here.
Yes, Dr. Lima, whatever you think is best. If there's I agree skipping the video may help with the stream. If there's any more still pictures or audio you want to go through, then happy to finish out whatever you think is the most critical information.
He's frozen. I'm wondering if it's not a bad idea to get Mikhail to talk, Said. Maybe
Yeah.
Lucas, what do you want to conclude, or you prefer to get Mikhail to talk, Lucas?
Yeah, let me try just once. Not working. Can you see my screen?
We can see now.
Yes.
Seems to be moving a little better.
Okay.
There were several portions where you were frozen, Lucas, so.
Let me see. If it's not working very well, I can just put in the other screen here. Maybe it will work better.
Seems to be working now.
Okay, so I'm not going to put the play here. This is one thing. First, the technical challenges of the surgery. The second challenge that we see here in South America is the language barrier. So my English is not very good, but the scenario is a little bit worse here. There are a lot of neurosurgeons that do not can read in English. So this is a concern for us, and because of these things, we decided to make this questionnaire and apply in the countries of Latin America, the 19 countries that are part of the FLUNC, and also in Portuguese and Spanish-speaking African countries. So we made this questionnaire with 50 questions related to neuroendoscopy, skull-based neuroendoscopy, and ventricular neuroendoscopy. This was last year during a 1-month period. So we included these 19 countries here with the red pins in Latin America, and also the 6 countries in Africa that speak Portuguese or Spanish. These were our responses, 202 responses, compared with other studies, a good number of responses with 104 cities in 18 from the 19 countries in Latin America. We just didn't have answer from El Salvador. And 4 of the 6 countries in Africa, the other 2 countries in that time didn't have neurosurgery services there, Guinea-Bissau and São Tomé e Príncipe. And what we found in this questionnaire is that about the structure, most hospitals have medical residency. Video and camera tower are very frequent, 88% of the hospitals of the users. Optics and instruments for ventricular or for skull-based surgery are also frequent, more than 6% and 7%. And adult ICU or pediatric ICU, most hospitals also have it. So specific about skull-based endoscopy, from those 202 answers, 145 responses, someone in the team performed endoscopic skull-based surgery. Most of the people work with pituitary tumors, CSF leak, and extended extradural approaches. Half work also with more challenging approaches, intradural approaches, transplant and transcribiform, or approaches in the coronal plane, or few places also work with vascular surgery. We try to separate to split these 2 groups here. So we try to find places that could work with those more complex cases. We found 34 centers that also perform more than 48 cases per year. This is a number we decided to put 4 cases per month. Should be a good place to have training for our reality here. So from those 34 level A centers, so yellow pins are those level A centers with more than 48 cases. Blue pins, all the places that perform endoscopic skull-based surgery. I would show here in Africa, so we just have Angola of the 6 countries that perform some endoscopic skull-based surgeries, but a few cases, not too much. Only 7 places have laboratories for training, for research fellowship. And we had 34 centers, 12 offering additional training, and the other 22 they want to offer training, but today they don't do it. We have basically two branches of endoscope that dominate the market, called stores and Escolab, but we also had other 8 branches mentioned. And these are the places that do not perform any endoscopic endonasal approaches. So we found 57 answers from 50 hospitals in 43 cities. In purple pinks, we have hospitals where they do not perform endoscopic skull-based surgery, but there is other place in the region, other hospital in the region that could do it. And in red pinks, we have places where people answered that there is no other center also performing endoscopic skull-based surgery. Once again, in Africa, we just have in Luanda, in Angola, other places performing endoscopic skull-based surgery. All the other countries, there is no endoscopic approaches. And we asked the reason for not performing the techniques, and basically we have 2 answers. First of all, is training. Most people do not have specifically trained, is not trained for these approaches. And then we have equipment. 42% of the centers, they answered that equipment is also a concern for these procedures. So to finish, I just want to discuss some topics and share some ideas we have here and projects we are trying to run. So first of all, observational and clinical fellowships. We need to have more of this, especially here in Latin America. So most neurosurgeons that want to train have to live here and go to United States, Canada, Europe. But I believe we have like some islands here of places with a structure and training, big cities in the bigger countries, Brazil, Argentina, Colombia, Chile, with structure to perform challenging cases. But there is nothing to link these people. I put here Intersurgeon. I don't know if you know the website, but this is very interesting. It was created by pediatric neurosurgeons. It's a place where you can find people interested in training and people interested in offering training. As Claire said, here the anatomy laboratories are very few, so this is something we need to have more to create more centers, to have support for more centers, or to have facilities to go to other places. Yeah, we have today. We have after the COVID, we have a lot of webinars, but there are other forms of physical and virtual training modules, and I believe this is very good. The webinars are very good, but generally we are going to have 1 month of section of vascular neurosurgery, and then 1 month of skull-based neurosurgery. And what we are trying to do here, we are trying to organize a course. We are talking with one of the medical schools from here in Belo Horizonte that have a structure to conduct an online course, and we want to perform a course with lectures of endocrinology, ophthalmology, radiotherapy, neurosurgery, anatomy, everything, to have the whole team trained for these approaches, for initially for pituitary tumors, but also for other skull-based, more complex skull-based approaches. We are trying to organize this in Portuguese and in Spanish. So I wanted to do it for free, but there are the costs of the university. We are trying to do it for a low cost, so we can perform first a complete training of other neurosurgeons, and after that we can think in missions or other types of training. I put here something that Claire wrote, we cannot, it's not, in my opinion, like he said, we cannot just go for a place and with expensive instruments with specific training and perform some cases and do not have trained people there. So my opinion, first we have more work to do before, and then we can go and lapidate the training of these people interested in training. And after that, there are other forms of continuity training, telemedicine, distance mentoring. This is Dr. Benjamin Worf with his project NeuroKids. He's doing this in Africa and also in Latin America. So other forms of treatment. We need support from the companies. This is from the website of World Federation. We have sponsors for some microsurgical instruments with Escolab. We have a sponsor for microscopes from Zeiss. We have a sponsor from high-speed drills, but there is nothing about endoscopic instruments and sets. So this is something the committees could work with too. And to finish, we need to work with public policy. We need to, my opinion, to build a consensus, issue statements and make recommendations for the national societies and also for public ministries. Mikhail has some experience with this. Maybe he can talk about later. So that's it. That's my thoughts, and hope we can discuss and help to create something a little bit better. Thank you all for the attention. I'll stop sharing here.
That was wonderful, Dr. Lima. I really appreciate the extensive work that you shared with us, and I think it's exactly the type of work we need to keep replicating to figure out where the problems are and then hopefully where the solutions are too. I think just being mindful of time, I do want to give Dr. Saleh the chance to get through his talk, and then hopefully if people are still around, we can have questions for everybody at the end here as well. That's okay. Perfect. All right. So next up, and finally, Dr. Mikhail Saleh. He is the current neurosurgeon at Maputo Central Hospital with a subspecialty focus on skull base and spine surgery. He completed his skull base fellowship in Brazil, actually, under Professor Luis Borba, and also has a PhD in neuroscience. And he's currently the president of the Association of Neurosurgeons of the Portuguese-speaking African country. So really excited to learn from him as well about the challenges of neurosurgery in Mozambique.
Okay, thank you. First, I would like to thank for this invitation and to be a part of this webinar with great names of the school-based surgery, the world, like Professor Prevedella and Lucas. So I'll start share my screen. Are you see?
Yes.
Can you see my presentation?
Yes.
Okay. Now you can see.
We see the slides not in presenter view, but we still can see the slides if you want to click through.
Okay. You see the slides, okay?
Yes.
So I will talk about my experience and the challenge that I face daily here in Mozambique. My name is Mikhail Saleh, I'm a neurosurgeon for Mozambique, and I made my medical residence in Cuba during 5 years. Then I spent 2 years with Professor Borba doing my clinical fellowship in school-based surgery. So I come to my country last year, and I'm from here, Mozambique. Mozambique is the Southeast African
Dr.
country.
Saleh, I think
Yes.
the slides, we still only see the non-presenter view. So if you perhaps try slideshow, view show, we're still just on the title slide.
I will stop and okay.
Sorry about that.
Are you see now?
Not yet. We see you, not the presentation.
Oh, I will try this. Now?
Yes, we see the version we still see your slides on the left-hand side. So if you want to click through them on the left-hand side of the screen, then we should be able to see each successive slide.
I will try. Let me do this again. And now?
Again,
Sir, you
looks
can click on the slideshow button.
But you see the slide.
No,
yes.
it's just fine.
We don't see it full screen as a presentation. We only see the slide as if you were creating the presentation. So if you have it on that view and click through the slides on the left-hand side, we can still see them, just like Dr. Lima did again.
Okay. Let me. And now? Still.
No, sir, not yet.
Not yet. Oh, I have a problem here.
Yes, if you
Okay, I
just
will try.
yes, go ahead. If you have the slides as you had them initially, then instead of using, the slideshow
Okay.
mode, you can just click through them and then we can at least see.
Okay. Okay, I will try. Let me. And now you can see.
Yes, we can see. And then on the left-hand side, we see your next slide. So you just click there. It should be okay.
Okay.
Yeah, you can keep it this way. Just keep moving the slides exactly like you just did.
Okay. Okay.
Click in the one that you want and it should be fine.
Okay. Okay. Thank you. So Mozambique is a southeast country in Africa. We are border with South Africa, Zimbabwe, Tanzania, and Malawi countries. Our official language is Portuguese, and we are 34 million people. According with HDI, we are low MIC country. So the neurosurgery in Mozambique is the same with many countries here in Africa. We are only 16 neurosurgeons for 34 million people. So in Mozambique, we had 4 neurosurgical service and only one school-based neurosurgeon. We have 2 centers that we have a program of neurosurgery and 2 residents of neurosurgery. The neurosurgery program in Mozambique during 5 years. So this is my hospital, Maputo Central Hospital. We had 15,000 beds and 15 operating rooms. Our neurosurgery service had 7 neurosurgeons, 8 residents, and 4 beds. So let me pass. Okay. The main cases of the admissions in our hospital, as many countries here in Africa, is the traumatic brain injuries. Then we have spine injuries, hydrocephalus, and tumors. About the school-based lesions, most of these lesions are basically fractures. Then we have meningiomas, pituitary tumors, schwannomas, and others. But this is our reality for school-based surgery. In Mozambique, we don't have microscopic. we don't have endoscopic, and this is our reality. We still have basic instruments, and with these basic instruments, we try to do our best. Fortunately, in Africa, we have the same, the same cases, we have the same reality, but some countries have a particularly difficult. In Mozambique, still have these difficulties. So this is our one of the most cases that we face our in our works. For example, this is meningiomas. We have schwannomas, and we still have difficulties. Our difficulties, as Dr. Clay said here, with the papers, as the same. We have a lack of adequate instruments to school-based surgery. There is not enough investment in neurosurgery in our country. So as I say, my presentation will be short because in school-based surgery, unfortunately, we have a many difficulties to have instruments to perform our surgeries. You can see my slide.
Yes, yes, we can. I appreciate
Okay.
it. Looks like you're on coming towards the end there. Is that right?
Please look for this slide. This is our instruments, our device to perform our surgery. Okay. So as I said, my presentation will be a short, and thank you for
Thank you
this
so much.
opportunity. Thank you, Professor Provedello.
Well, thank you. I think that we've really seen a full spectrum today, even in just these three examples of the different challenges that people face in
Yes,
different.
yes. My focus will not be say about tips and tricks because it's already spoken by my dear colleagues here.
Yes,
I
much
think
appreciated.
yeah, you did a great job closing the main aspect of the goal of this discussion, which is the difficulties, the lack of equipment, something that Claire mentioned, how much she worked in the
Yes,
beginning there, like to be able to build not only for courses, but also to be able to do the cases, get a microscope here, a tower there. I remember, Mikhail, when we talked early in March that I had the pleasure to meet you personally. You mentioned how difficult it is. You have to use towers with urology. They have priority. Priority is non-neurosurgery in these places. That was very impressive and shows the reality, how difficult it is. And I think the whole world we're trying to help, but there's limitation. You guys have a population that is millions and millions of people there that need help, and well, we do what we can do. So, like I mentioned, Claire will be happy to help you with the next adventure for courses there. We can be in touch, and maybe we can do something with Mikhail together, and Lucas and Said, and a lot of people listening here. Anyone has any idea to how to improve and make things better for the developing countries? I think we're all happy to help. Said, what do you think?
I think that's beautifully summarized. The themes that really jump out to me are indeed the training and the equipment. And I think one of those, at least from a training perspective, is something that we can try and bridge the gap even overseas. I think this idea of doing tele-mentoring and long-distance mentoring, like Dr. Lima mentioned, is one area that we really have the opportunity as early as now to do without requiring millions of dollars. So I'm really thinking hard about how we can do that at a high level and at scale. So I'm really excited about that. I see Dr. Abdul-Bar unmuted himself as well.
Yeah, thank you so much for the speakers. I think this was a wonderful tour of, the challenges as well as, the solutions. And I think that, as Dr. Prevedella said, we'll be working hard to, find those solutions so that it's not just makeshift, but also taking us to the next level. And I think that, some of the tricks that you have mentioned, they can actually be transferred from the LMICs to the HICs and back and forth. And I think together we'll make this a reality. So. Thank you all to the speakers and to all the people that attended it. I think we can have a few minutes for questions, Syed.
Yes, absolutely. If anybody in the audience has questions, by all means, feel free to fire away in the chat. But otherwise, I can start us off with at least one. For Dr. Karakezi, I think one of the things that shot out to me was you did these amazing, beautiful surgeries, really intense, and then a patient would die postoperatively from hyponatremia, for example. So how do you bridge that gap of being able to provide your niche area of expertise, but really still being reliant on good endocrinology care or even good ICU care, all these other elements that go into taking care of your patient?
Well, thank you, Adil. I think it prepares you to the next case you do, because like for instance, the last case I did of tuberculum cell that goes behind above the diaphragm to the prepontine. I think that lady also had transient DI, but my resident, we just learn how to manage such patient because, you cannot wait forever for the endocrinologist. Even if there is a need for endocrinologists to be there, we try as much as we can to do like the ICU for our own patient, the endocrinology for our own patient. So you learn how to manage those complications. You learn from the previous case, and you expect the complications, and then you're waiting them at the end of the case. It's not like they're not going to happen. I think even in HICs they'll still happen, but they'll still managed adequately. It's not like you can avoid them. Sometimes you cannot avoid them, but you do know how to manage them. So we just learn how to manage them.
Yeah, I would like to make a quick comment about that because as Claire, I also had a problem doing cases around the world. I over the years got invited to perform and then do some demonstration during courses, live surgery over the world. I'm not going to mention the country, but I had a patient that I always, when I do that, I round on the patients for 1 or 2 days to home, feel that very well. And then like something that you've done. And so the bottom line is that they did not recognize the hyponatremia was an issue to correct quickly. So they actually corrected extremely fast a hyponatremia, and the patient ended up with a lesion in the pons. So that shows how important is perioperative management. It's just not the surgery. That made me really meditate and think about a million times about doing surgery abroad. Those things can happen. It's amazing, like Claire explained very well, like it's just not us, it's a team of people. You cannot take care of patients by yourself. You need the nurses, you need the teams, you need the ICU. And this patient example I gave was also in the ICU. So just ICU, it doesn't matter if they don't have the preparation, the knowledge of things like that. It can be difficult. So the only thing you can do is to educate people around you, Claire, for next stage, and kind of keep teaching and working hard, and paying attention on the perioperative period, as pre-op and post-op are very important as well. So I agree with you. I have a question for Lucas very quickly. Lucas, could you tell us like the mechanism from people from Africa to do fellowships in Brazil? Just if you could briefly mention that, because I think we have some examples in the audience, but what one need to do from Africa to have some fellowship perform in Brazil? You're muted, by the way.
For fellowship or for residency?
Either way, any training.
Yeah, I believe there are more programs of residency, but of course there are for fellowships also. There are some agreements. For example, I have one resident now from Angola, from Luanda, Fábio. And it was an agreement with their government and the university here in Belo Horizonte. So the theater was to their government and not direct with us. But I believe there are something about WFNS also problems in, for example, in the north of Brazil. Anna is here. Yeah.
Maybe Mikhail can explain how you did the fellowship with Professor Borba. Mikhail, was you reach out personally, or there was any other mechanism?
Was personally, professor. Was personal.
Right.
My
Claire,
government don't have a support
Mhm.
to do residence out of Mozambique.
Right. Claire, do you want to say something?
Well, yeah, I think, from that time, I think Lucas and is it Mikhail? I think we're all in the same, same age of practicing, and it's probably some period of training. And that time there were no so many training programs. So my own experience is I just wanted to do neurosurgery. There was no way I could do neurosurgery. So I went to the internet, interestingly, and I found the WFNS. And when I went to the website, I saw that WFNS had training programs, and I saw that there is a program in Morocco. So that's how I ended in Morocco. It's not like someone recommended me. It was me digging, finding a program for myself. So the fellowship, same. So Morocco, kept going around, meeting people, meeting Golby, meeting everyone, opening doors, connecting, and, finding the next opportunity. So that was the time. Now I think in Africa, we have so many training programs. But I think it's the time we shift from basic neurosurgery to specialized neurosurgery, because, those complex cases exist, those complex spine cases exist, complex vascular cases exist, complex skull-based cases exist. So we're good in terms of trauma, and all other stuff. But we need to now start thinking about, being efficient in more those complex cases. And I think that's the role of maybe building skills lab or fellowships and etc. And collaboration, of course, with HIC.
It sounds to me, based on your presentation, Claire, that you could have your own fellowship there now. You're doing
I
some
think
good
I have a pretty great number of cases,
Yeah,
but I still struggle. But I think it's coming. Maybe in 2 years, and so I can have. So far, people will come maybe for the course, which is good. They get the skill, but 5 days is not enough. Then you need to go to the theater, and you need to see those cases being done, and that's the role. And I think I grew up so much when I was doing my fellowship rather than when I was doing my residency. So it's you have to get there.
Very good.
No, I think it was particularly illustrative, Dr. Karakezi, when you mentioned that you went to a skull-based lab, you saw a case, and then that gave you the confidence to do it the next day or the next.
Yeah. I've seen it several times, and I will see the FTOC, but I said I can never do it. But when I did it, and when I saw the patient, when I saw the one piece, when I saw the cosmesis, I said, okay, I'm there. I've done it. I just done it,
Right.
Yeah.
I think it's those short moments that give you the inspiration to then take it on, and then you become the teacher the next time around. So this conversation has got me thinking more about how we can ensure that people get those maybe low number but high quality learning opportunities, so that they can then have the confidence to tackle those cases, learn the nuances themselves, and then share that throughout their community. So I'll pause there, see if anybody else has any questions, Dr. Abdul-Bar, or from the audience. And then if not, we can be respectful of time after another 1 or 2 questions and close it out. So I see a couple of comments just from the audience as well. We have people from Madagascar. We have thanks for multiple presentations. Sayed Ali, I was asking about the number of MRIs and CT scanners. Obviously, that's very different in different countries. So we heard a little bit about that, and we can point them towards, perhaps via email, the final numbers on those. And then I see other people sending links for other updates. That's great. So anyways, Dr. Abdelbar, any final questions? And then I'll just tell everybody about the study that we're hoping to do, and then we can close out. You may still be muted. Yeah.
Sorry, I'm muted. I think this is a great first start. So maybe you can give your idea, and then I think we can wrap it up.
Perfect. Yeah, so just so everybody knows, obviously the neurosurgeons in the audience, we are hoping to formalize this type of this topic about how do we grow skull-based surgery through a publication where we hope to survey neurosurgeons formally and as many LMICs as possible to really get a sense for what their current capacities are, what their biggest challenges are, and how we can hopefully take the next best steps forward. So we'd love all of your inputs in this. If anybody's interested, I'll put my email address in the chat as well so that everybody can see it. It's just my first name dot last name at duke.edu. But please do keep an eye out for that survey, fill it out if you can. And I'm open any point to speak via email or Zoom about anything at all related to this topic. Would love to help make sure that we continue growing our skull-based capacities around the world. So with that said, there's my email. Really appreciate everybody joining tonight, especially our speakers, Dr. Prevedella, Dr. Abdelbar. It's been terrific. So hopefully we'll talk more in the future.
Have a good day.
Have a
Thank you
good
all.
day.